Hello, 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 everyone. Happy Sunday, and welcome to Power Time. This is Sharon Herbert, the Power RN, coming to you live from Power in Nursing Innovations. And we've got something to share with you. You know, some of you know me and some of you don't. So let me just wrap that up really quick. I just wanted to let you know that yes, you are at Power in Nursing with Sharon Herbert. I've been a registered nurse for many years. And some of my gifts actually worked in concert with some of my challenges, and some of them, as some of you will know, your own self, some of your challenges just seem to butt heads with your gift. So that's kind of where we're heading today. If some of you have had your dreams revisited, I welcome you as well. And as we say that, I am always looking at what's happening in nursing, and whether or not it makes, I don't know, I'll just say whether or not it makes sense to where we are in the world of nursing. So, as I look at, well, you know, we're supposedly just finishing up with the pandemic, but as we look at that, where is nursing? Where are we? And what is the future of nursing? It is really a challenge. It seems such a tumble that we can't figure out what to do with the community that we have, nursing providers, caregivers, and we are waiting, and we're still waiting. It seems we're still waiting for some big giant magical thing to happen, and we're still waiting because it hasn't happened yet. Nurses have left the profession of nursing, as you all know, over the last year and a half for sure. And the new grads really made it very clear before that year that they weren't having any of whatever is going on in nursing, and it's not what they heard in the book. It's not what they knew or thought or even chose to be ready for someone to tell them how this nursing thing was going to work, because they heard some things from their mentors or from their faculty or from friends or family or on the media that they weren't really sure about how this would work. And as we looked at the numbers, we see that the numbers of nurses has diminished over and over in the last weeks, months, and certainly in the last year. And wow, what are we going to do with that information? What are we going to do with that? We look at the data, and every week you see nursing shortage, nursing shortage, nursing shortage, nursing shortage. And where are we going? Have we solved any of these problems? And if we have, let's show the evidence of that. And if we haven't, why not? Why not? Why not? It seems that certain folks or certain positions have remained in the same places, but that hasn't made a change. It hasn't made a change in the numbers of nursing staff or the longevity of those staff members, including the new grads. So what do we do? Now, once upon a time, I'll make this short, once upon a time, I decided to get myself in the position that I could help nurses even more than when I was at the bedside and helping them through orientation or preceptorship, etc., etc. And I decided to take some more steps and get the information and the education to present with a doctoral degree. And I chose Doctor of Healthcare Administration because my goal was, as I said, butting head with my challenge, my goal was to help nurses stay on track with the work that we do, the purpose, the practice, and that we would decide how those things are accomplished. Not someone in an office or in a box that didn't really know what we do. So that was the goal. And then came COVID and some other stuff. But now we are looking at, even looking back at the research from COVID times, you will see, yes, there was lots of rush to the door for new grads, and for experienced nurses, retention was certainly a problem. And what happens when those nurses leave is that, yes, your numbers shrink, but so does your expertise and experience to present care providers in the health and wellness workspace and workplaces. And people were coming to the ER and coming to the ER and coming to the ER. If they had insurance, they could probably get service at certain places. If they didn't have insurance, they could probably not get seen at certain places. And some of those folks were sent home because they didn't have insurance. Some of those folks never came to the hospital or emergency room or even tried to get help or care because they lived so far away from any health care organization, office, or system. So they just stayed home. Now, we know that COVID, yes, started somewhere and grew and grew and grew. And the folks who didn't have access to health care, either they got very, very, very sick and or shared the COVID with the members of their family. Their kids got COVID, or their kids got COVID at school and brought COVID home to them. Lots of no's. No and O is about how they were served. And we're still in some of those places now, wherever it's rural conditions, it's health inequities and inequalities, disparity, diversion, diversity. These are all words you've heard. And it still hasn't changed. I often reference, if you've heard me, a few areas here in the lovely valley of the district, Maryland and Virginia, and we call it the DMV. And there are certain neighborhoods and communities that have differences in the demographics from neighboring communities or neighboring states, or just people who just don't get the right information. And those, any of those, can suffer. And as well, we're keeping track of the numbers, CDC and the labor statistics and all of that will show you who's getting care and who isn't. And very well, it will show you that folks who live in poorer or rural health is not rural health is not a thing. rural health is not a thing. If you're in a space or place where there are no providers, no access, no grocery stores, no pharmacies, those places aren't everywhere. Folks are missing the information and the items that could be available to help them be well. And right out, I'm going to say, you all are going to learn some new things about Miss Sharon, because there's a change. Last week, I talked about it's time for change. It's time for change. And if you have not been paying attention, the CDC is not really collecting information about COVID since the pandemic. The pandemic doesn't exist anymore, so that was May-ish or so, and so they don't need to collect data. Well, COVID is still here. COVID is still here. It's in the workplace. It's in the library. It's in the grocery store. It's in the bus plazas. It's in the every space that you can even think of. But it is not officially a pandemic, even though one of the health systems in Upper New York mandated their staff to start wearing masks again. Now it is required because there are so many persons with COVID coming into the emergency rooms and walking through the places. They could go to the cafeteria or even the restroom, and that COVID is coming with them. And they are spreading COVID to the healthcare workers. And the workers were getting sick. And now you already have a shortage of staff, but now you have lesser staff because they're sick, because now they have COVID from the patients, clients, customers who have come into the hospital or the health organization. Now, none of that makes sense. None of that makes sense. And if you're only talking about now one hospital and one place that COVID has been spread to the care providers and workers, it's happening other places too. Just because we're not counting the numbers does not mean that COVID isn't spreading. People are still piling up in the ERs and in the ICUs in many places. And how are they being served? How are they being served if staff are ill? And the things that we can do, no one's even looking for solutions. Now, why is that? Because, once upon a time, we talked about, getting more people to talk to communities about COVID. But, no, we had to kind of nix that. The world had to nix that because that meant that they'd have to pay staff to go out to communities to share the information and collect data and information as well. And no, we can't spend money on people just walking around, and surely not nurses, because we'd have to pay them way too much. We need to get back to basics. Community health and public health are great places and spaces where we can meet the community. We can answer questions. We can help them find out information and ask what they're thinking. What has been the greatest challenge to your community? even though you don't work there, they're having challenges. And if you look like me, a nurse of color, you will find that many of the members of your community, when they find out or discover that you are a nurse, they have lots of questions. And that is a great thing, that we can help them to be healthy and well and have the answers to the questions that they're asking. They'll tell you the story about their aunt or their uncle or their mother or their father or their sister or their brother that went to the emergency room in the pandemic, and they were sent back home because either it was too full, too long a wait, they didn't have insurance, it took them 3 hours on the city bus to get to where the nearest health clinic is. And we didn't want to have that on the city bus, but that was the way that people traveled. We need to help them find out the best ways to get information. And that valid information can be shared throughout their communities. We need to have health fairs, question and answer sessions at your community centers, at your neighborhood gym, at places that people can gather or have gathered before, a library. There are many, many places that we can host a conversation or Q&A about COVID today. COVID is still here. And you know that this is true, if you are a person of color or nurse or healthcare provider of color, you've had a challenge one time or another, either yourself or with a family member, understanding what they were told when they got to the doctor's office. Now, I am not saying that this is magic either, but you know that this is true. Health disparities have been rampant through communities. Communities of color are not always provided care and service. And sometimes even if they are provided care and service, communities of color are not quite the same as communities of folks that are not color built communities. Whether it is Latino, Filipino, African American, Slavic, Cuban, and we don't want to talk about Haiti and those well back rural communities, Alabama, Mississippi, and some others. If you go to New Orleans and you start asking someone a question, you'll know full well if you all are able to communicate. And we know that in certain areas as well, there are things that we have to ask each other about what is going on. Don't tell me if you've ever been to New Orleans and it was your first time that you had no idea what was going on when they talked about po' boys. Po' boy? What is that? There are several other things that you don't understand if you are not from that community. And you may not get the information, correct and valid information, to help you find your direction to where you need to go. And Having said that, what does diversity mean in your organization? Because as we serve the public, we need to be able to communicate very clearly, and have a means to validate the clearness and information was accurately shared, and that the person understood what you said and they heard clearly, and you validate that information or pose a question that will help clarify that information. And as we talk about all of that and the numbers and the nursing shortages, it is very clear that folks that look like me don't always get served to the best of the ability of nursing. If you look at the data, if you want to look at that nursing shortage and or diversity or Board of Labor statistics, you will find that registered nurses of African American descent have a very, very low number, maybe less than or equal to 4 to 5% of health care leaders. That means, yes, supervisors, managers, directors, all of that are African American nurses. The greater number are Hispanic. A greater number are Asian descent. And the greatest number are Caucasian nurses. Now we know, and if you don't know, what do they say? Ask somebody. Ask somebody. What do you think about that? What do you think about that when you are asked why you do a certain thing, why you wear a certain thing, why our hair is in a certain way? Other folks who aren't in our communities or in our culture might not understand the why. And it is not all the same for each and every person, for sure. But does your workplace acknowledge that it might be important to help promote retention for nursing staff and best outcomes for the community that has come for service, but they have no idea how to get their medication, where their medication can be found? How do you spell that? Lorazepam. What is that? How do you spell it? Where can I get it? What does it mean? What can I do? Well, my grandma did a certain thing, and we didn't take those types of medications. You'll find lots of stories in different cultures, and we have to pay attention to what people are asking. Body language is so important, as you can see here. Pay attention to the queries that you get. If you are the discharge planner, the case manager, how can we get the good and right information to our clients, patients, customers, so that they can be well at home and continue with a strategy for health and wellness if they don't know what you're talking about? We've got to pay attention to the color in nursing. Now, we've talked about the power and will continue to infuse that power. But I'm going to give you another thing, food for thought. Diversity matters. Clear communication matters. We have got to get off of that. I'm going to give you a piece of paper. Discharge teaching is on a piece of paper. We've got to talk to those persons to determine what is next. Is the message clear, or do we need to do more? What do we need to do that's more than what we've done to have best or better outcomes for those persons at home so that they don't get ultra sick and have to be hospitalized on the ventilator and in the ICU because they didn't know what kind of medicines that was on that paper and how I needed to take them, when I needed to take them, if it was okay to take it in the nighttime or should I take it in the daytime, because it's something that's called, I think they said Lasix or something. Can I take that at nighttime? Now, you all know the answer. The color in nursing is our new strategy to promote the best life for our health care providers and the best outcomes for those clients. And I want to thank you all. I see you. I want to thank you for coming aboard. Well, you know, what most of us know or may know is that Miss Sharon here is talked about the 3 E's. And that's an infusion into this color as well. We need to give our community access to finding out how they can find out information. And education, experience, and expertise are not just for you, my nurse friends, not just for you. It's for you to use now that you've gotten those 3 E's to help your community get better, stay healthy, and be well. You've got the information already. You've got to share it and help the persons that you know, love, and see every day be healthier. And we're going to do that by investing in our nurses of color. And you all, if you don't know, there's a new group. It's about a year or so old. Doctors of Nursing Practice of Color. It's a new strategy that we can engage to help us to help the community as well. And for the registered nurses that are here today, you're here today. Let's invest in the 3 P's. Well, P plus P plus P equals P. Have you got that? P plus P plus P equals P. P is for practice. That is the practice of nursing. Second P is for promise. It's the promise that we've taken to use what we've learned and the practice to help people be better and well. The third P is promotion. promotion. We can't just keep this third P to ourselves either. We have to promote what we know. We can't just keep it in a box. You know, I talked about that little treasure chest and your toolbox. Take what you know and share it with the community. And each of us will promote each other. And this is not a P, but we're going to take that word just out of our vocabulary. You're not just a nothing. You will use your practice along with the promise, along with the promotion of your nursing ease, education, experience, expertise. We'll use those together to create our last P. And you know, what could be that last P? It's the P that I love and I bring forth to you. Power. We have the power to make change in our communities, in our lives, in the grocery store, in the library, on the bus, on the train, as you meet with your family members, you're picking up your kids off the school bus. We're still needing to engage the strategies to unleash our power to save the world, our power to bring health and wellness back to our communities. Nurses, you can do it. You can do it. Follow me on the journey to color in nursing. We're going to branch out to differing communities. We're going to impact the world one community at a time. One community at a time can make a change. Surely we can do this because you know that you are brilliant and you can do anything. Let's bring those 3 P's. Remember them? Write this down. Practice, the practice of nursing. The practice that has taken you many, many years to complete. After you've completed the first P, learning about the practice, we will embark on the promise. The promise that we made. We've taken an oath to share what we know to change people's lives. And then we will change those lives by telling everyone we know what we know and how we can help them to help themselves and other persons in their own community. How to engage in health and wellness. And we know that we know how to do these things. We know our inner strength is the platform for our power. We don't shy away from knowing what we know. And we are fabulously equipped to do the thing that we have been chosen to do. So let's engage those 3 P's. Remember, we can't just talk about the thing like we're talking now and say, well, I did a video and so I told people. We've got to get out there and do the work and do the work and share with people that need the help that we can give. Let's do the thing. We'll talk about more. And once again, you can find me on Facebook. And you will find me, of course, on LinkedIn, Instagram, da 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 da. But I'm going to tell you, yes, I will still be here. But I will be in churches and schools and over sharing information about how folks in the community can be healthier and stay well. Home health care, we've got to partner. Community health care, we've got to partner and get the change that we are bringing to the community. Let's get that change started. Let's get that change started. So, we will see you if you are in any setting that you have questions about for health and wellness in your community. You can find me, as I said, on Facebook, Instagram, blah, blah, blah. But I'm going to tell you, the color in nursing is my second phase of the power. Color in nursing. You all know how to talk to folks in your church. You all know how to engage with people that have questions about, well, why can I use this, or can I not use that, or I don't really think these medicines are working, or I don't have a blood pressure machine, so I can't even take my blood pressure, so I don't know why you all are bothering me about taking a medicine. Oh, well, what? We have hypertension. That's a historical challenge and a cultural place that we need to step into as well. But we can do it. We can find each other and we can work together. We've got to make a change in our communities and in our places and spaces where we work, where we live, where we breathe, where we go on vacation. You have got to be the model for what it's like to help and care and serve. So we will see you. We will see you so very soon. Thank you for joining us. It's Power in Nursing.